I'm Stacey Lazar, operator for the Cornea and Laser Eye Institute at the CLEI Center for Keratoconus. I'd like to thank you for taking the time out of your nights to take part in our first patient perspective webinar. So tonight we have the opportunity to hear from 4 patients who will discuss their individual experience, whether it's surgical, non-surgical, like contact lenses. Please feel free to share any of our webinar invitations out to friends, family, support groups, anybody that you know that has keratoconus. Question and answers. We're going to be handling it a little differently. So if you have been on our other webinars, we've always saved until the end. But this time, what we're going to do is at the end of every patient, once they're done talking, we'll probably have a few questions that are just for that patient if we get any. And then any general questions we're going to do at the very end. Okay, so if you have a just type it into the question box on the bar, and then your audio will be the only way to ask the question. We're going to try to stay on key for our 1 hour time frame. So if we don't get a chance to answer, you can always email to the office at info@vision-institute.com, or you can send it to me, slazar@vision-institute.com. So on that note, I'm going to hand it over to Dr. Greenstein.
Thank you, Stacey. So yeah, we're very excited tonight to be able to hear a different perspective. Most of the webinars, really all the webinars we've done, has been from the doctors' side of things and what we experience. But I think it is probably more interesting and informative in many ways to hear from a patient's perspective. So we're going to start. We're first of all very thankful that we have 4 excellent patients here tonight who are going to share their experience with us. The first is going to be Jay. Jay Hammerstead underwent a laser-guided cross-linking. This was done in 2019. And so he's going to talk a little bit about his experience, and then we'll go over a little bit about what that procedure involves. Jay, take it away.
Thanks. Can you guys hear me?
Yep, you're good.
Thanks a lot, Dr. Greenstein. So yeah, I guess, a little background about me. I first was diagnosed with what they thought was an astigmatism when I was probably 22, so almost 20 years ago now. And then turned out later to be keratoconus. I sought treatment from a few different doctors who tried to fit in with hard contact lenses, which I really found uncomfortable. And so eventually I started trying to look for a solution that would, one, kind of halt the progression of the disease in my left eye, which is where it was getting worse, and I was getting ghosting, and my vision quality was getting worse and worse, especially when I played sports. And so I did some research on myself. I found out about cross-linking from my doctor at the time, and then started doing more research, and I was able to discover that not only can they do cross-linking, but there are also some new techniques that could improve the shape of my cornea to help improve the vision. And since I was, not really tolerating the hard contact lenses, I looked on the internet and found Dr. Hersh and the Hersh Vision Center, and then went in and had my procedure done after kind of talking to them. And I've been pretty happy with it. I think my vision's improved pretty dramatically in my left eye, which was the eye that was pretty bad. The ghosting is much reduced. Without contacts, I see pretty well. With contacts, I see much better. And so for me, it's really been a good solution in terms of trying to find a way to stop the disease, but also to get better vision as well in the meantime. And happy to answer any questions if anyone has them.
Excellent. So I think what I'm going to do here, Jay, just for a second, is I'm going to share my screen just to give just a touch of background on the procedure you had done, and then we'll go through some of the questions here. So, okay, so hopefully everyone can see my screen here now. So, the experience that Jay describes is what we call a laser-guided cross-linking. And just to take a quick step back, when you have regular cross-linking done, the standard FDA procedure, we basically use a sponge on the cornea, which is soaked in a diluted alcohol solution, and we brush the surface layer aside to expose the center of the cornea for the cross-linking treatment. And now with what we call topography-guided PRK, we have the ability to use the laser in a very customized way right over the areas of steepening. So in LASIK, when we use a laser to correct your vision, we give a very diffuse treatment, as can be shown kind of in the top right here, based off of your glasses prescription. But with topography guided PRK, we use the map of your cornea. These purple areas are the steep areas to flatten the surface. And this gives us a great way to expose only the area of disease and only the cone. So this is an example of using the laser, you can see in the top right, to remove the surface layer, the epithelial layer, just over the cone area, and then do cross-linking after that. And if you look down below at the maps that you see here, the middle map was before surgery, very typical for keratoconus. So a area of steepening down below, the pink and the red area. And then once the laser has removed the surface layer and the cross-linking has been done, we can see here all of the blue flattening. And really, when you look at the map afterwards, the map is very, very green and very normal looking. So just to give a little background on kind of the general results we've been seeing from this, vision without glasses has improved on average by about 4 lines after this type of treatment. And vision in glasses has improved by another line. And as Jay kind of described, a lot of patients will describe that not only does the vision improve, but particularly the quality of the vision improves. So that ghosting that you experience can be made much better through the laser. And obviously with contact lenses can be improved even more. So the one thing to note here, though, is in this graph, you can see that the prescriptions for patients also improve. So at the beginning, the general prescription was around a little over -4. This goes, improves and is less nearsighted, about -2.8. But the key is that it does take some time. And I think Jay can probably attest to this, and I'd like him maybe to expand on it a little bit. It doesn't happen right away with this procedure. You don't notice the first day or even the first month that everything is better. It really takes 6 months to a year before you get the full visual result from having this done. And just, finally on the flattening side of things, on average, we've been seeing flattening of about 3.5 diopters. So patients go from about 56 diopters, which is a measure of steepening, to about 52. And to put that into context, with regular cross-linking, that average is about 1.6. So regular cross-linking, the average is about 1.6. With the laser-guided cross-linking, we're averaging about 3.5. And I think you can see it really clearly in this picture here. When you look at a patient who has had standard cross-linking done, this is pretty typical. Before the cross-linking was done, and then at 1 year, there's not a huge change. If you look at the laser cross-linking, and this is really actually Jay's maps of his left eye, the middle map is the before, not the 1 year, but you can see that it's pink and red, very steep. And afterwards, you can see how green the center map is. You really can't barely even see the keratoconus. And the difference is 1.1 diopters of flattening up top, pretty standard for cross-linking. And Jay actually had an unbelievable result of almost 17 diopters of flattening, which really improved vision significantly. So, Jay, I just wanted you to maybe expand a little bit, if you could, on some of the process of going through the treatment, maybe when you started to notice really that improvement happening and how long it took to get there.
Yeah, thanks. I think like you said, it definitely took some time. I remember, after I had the procedure, the first couple of weeks, some days my vision would seem better than it was before. Then the next day it would, seem a little worse. It kind of seemed to me like it fluctuated for the first couple of weeks or months. And then, when I went to my regular checkups each time, the vision was getting better. I could notice that when I was on the line charts, they got better. And I think even as recently as my last appointment, which was March of this year, and remember I had the procedure in 2019, we still saw improvement from my last visit, I think, which was 6 months before that. So, it's still kind of a steady process, and I'm sure I'm towards the end of it now, but it definitely got a little better each visit, and you start to notice, you feel, at least for me, because my left eye was so much worse, my right eye, I started to notice I felt my vision was more balanced over time, and it seemed like my brain was kind of catching up to the improved vision to kind of make me feel, you know, like my peripheral vision, especially my left side, was better too. So, yeah.
Right, so I think your story is pretty typical from what we hear, which is that even, and like you said, which is the amazing thing, even past a year, we can still see improvement. So if I remember correctly, I mean, I think, you know, your vision was even maybe around the 2030 range when we had seen you even just 6 months ago, and now it was, well, even 2025, I think even slightly better than 2025 when we saw you almost at the 2-year mark. So we already know from just regular cross-linking without the laser that there's a healing process that takes between 6 and 12 months. And I think that is even more dramatic when it comes to this type of procedure. So Stacy, were there any questions for Jay?
Okay. 1 second here. No, nothing specific. So we'll wait to the end for generic stuff.
Sounds
I
good.
think one important thing to mention here, remember when we're doing cross-linking alone, the main goal of that is to stabilize the cornea and decrease the progression of keratoconus. The topography guided aspects of things, the other kinds of procedures that we'll discuss, they are meant to improve your vision both with glasses and without glasses. So remember, cross-linking stabilizes the cornea. These other procedures improve the contours of the cornea to give you a crisper vision.
Absolutely.
And with that, I want to introduce our next guest, Michelle Hardwick. Michelle has been a patient of ours for a while and knows about any number of treatments for KC, and is going to be able to discuss her experience with the variety of modalities that she has used to try to improve her vision over the years. Michelle, thank you for coming.
Thanks. Yeah, from the intro, I would say it's more of a journey for me as going through this process versus finding the end game. I started having my vision trouble in my 20s, diagnosed with astigmatism, dealing with hybrids and different types of lenses for a long time, not happy with the vision. I did go for a LASIK consult outside of this group and decided to have a second opinion with Dr. Hersh to find out that traditional LASIK was contraindicated and that I had keratoconus. So I actually had my keratoconus diagnosis with Dr. Hersh, and that's probably 20 years ago now. And I was using many different modalities of lenses with Dr. Donald Hersh and Dr. Gellis with RGPs, hard lenses, hybrids, sclerals. And I think in each case, I always struggled with the day-to-day things that folks struggle with, whether it's with travel, plane rides, I snowboard, I've lost them in the back seat of the car under, mats and things like that. And it was really troublesome. And I started to get to the point where I was getting a lot of bruising. So I would take the lenses out, give them a rest, and that's where we kind of moved into the mode of considering Intacs and the cross-linking trial, which was the more traditional epi-off cross-linking. And that, I think, from all of the procedures that I had, I think was one of them. I was most nervous because it was my first, so I didn't know what to expect coming in, and how do you work on my eye and that type of thing. So I think I had a little anxiety coming into the procedure. It was much easier than I thought. I do think the epi-off took more time to heal than the next procedure that I had, but the combination of the Intacs and the cross-linking, really, I was not just on my left eye. I definitely was able to tolerate my lenses much better after that, and that was the goal of that procedure. I think it took maybe a couple of weeks where I was feeling, pretty fine and comfortable after all of those procedures. And then I was continuing with lenses for a while, and I came back to start to see if there were any changes in progression with the technology, if there were other things that we could do. I always had a dream or a vision of hoping to not have to wear lenses to wake up in the morning and maybe have even better vision. And that's where we started to talk about the topography guided PRK. And that was the most recent set of procedures that I had done. I did my left eye standalone. I know a lot of folks go and do both eyes at once, but always conservative, a little nervous. So I always like to see how things work on one. And the team was pretty open to kind of doing it what makes me comfortable. And Dr. Greenstein did my left eye. The results were really good. The recovery was pretty quick. And we moved on to the right eye. So I feel like for me, this is one of the miracle scenarios. I do not wear contact lenses anymore. I wear some glasses here and there for near vision, but for me, it's a tremendous, tremendous life change. So my journey was kind of nice having a lot of different modalities to be able to work through with the team. And the team worked really well together to be able to let me progress through, you know, my eye journey and see how things go. So that last procedure, it's a couple of years now, I think. And yeah, it's a pretty good success story for my life. So I don't know if anybody has any questions.
Thank you, Michelle. So yeah, I mean, I think the key, you know, here is definitely not one procedure is going to fit all, and also you may need potentially sometimes more than one to get you where you need to be. But we do now have the opportunity to do a lot of these different procedures for, you know, each individual case.
Michelle, can you remember how was the recovery between the different procedures?
The epi-off crosslinking was the one that was the toughest, the healing time, and just even pain after the procedure took a couple of days. I was more uncomfortable than the others. The PRKs, intact, those were both quick recovery and, you know, just kind of minor inconvenience over the next 24 hours, but a very speedy recovery.
And we removed and adjusted your intacts as well, right?
Yeah, so we put one in, removed, so we swapped and we took one out, yeah. So I would like to think of myself as the princess and the pea. Anything that bothers me, I come back and I'm like, I see this, or I don't like this. And so yeah, definitely made some adjustments and to get me where I am today.
Yeah, well, there's so many things that are now available for keratoconus. Obviously, as I said, cross-linking for stability. I mean, that is a no-brainer if you have KC are in a progressive age range. And that really is anybody who's young or anybody who's been noticing their vision changing. Then the ways that we can improve your vision from the surgical arena are intact, as Michelle had, which we've been quite successful with in the past. The topography guided PRK, sometimes a standard PRK procedure using what we call transepithelial technique. Other things like conductive keratoplasty, which is a little heat treatment that can stretch the cornea a bit. We sometimes use for fine tuning. So there are really any number of modalities that can be used to address vision. Of course, as Dr. Gelles will discuss a little bit, any number of contact lenses too have become available that can be used alone or in concert with these other techniques to really try to optimize your vision. Some of these are guided by topography, some by the different compound curves of your cornea. But unlike when we first started this in KC, which is now over 25 years ago, the number of things that are available and the number of things that are successful really have grown by leaps and bounds.
So do you remember how many years was it between when you had the intacts, the final kind of intacts exchange, and having the topography guided PRK?
I don't, you know, I don't have the dates in front of me, but I would say it's got to be 6-7 years at least. And I was happy with the, we were working with the hybrid lenses and doing just fine. So I didn't feel a need to come back. And it was kind of good because it let the technology marinate a little bit, and like Dr. Hersh is saying, things have changed a lot since I came to, work to be treated at the practice. So it was kind of a good opportunity for me to take advantage of some new things that were happening.
I think that's also, it's a good point to make, because I think one of the typical things that we've, as technology has advanced, we've been able to, further improve the visual results. So Intax was novel when it started. It allowed us to give much, better glasses vision to so many more people who couldn't have it before. But a lot of people who have Intax or have some of the procedures we've done are still, wearing contact lenses, and maybe didn't get as much of the improvement as they had expected with the one procedure. And now, with the ability to do multiple procedures, we really can get people, I think, to closer to where they probably wanted to be, at the beginning. So thanks for sharing.
Thank you, Michelle.
So, okay. So there were no questions, correct? Right, Stacy? I think.
Correct. No specific questions from Michelle.
Okay, great. So we're going to move on to then the next speaker, which is Sam. Sam is actually one of our more recent patients to have a keratoconus surgery. He underwent our new procedure called customized tissue addition for keratoconus, or CTAK. And so a lot of patients haven't even heard of CTAK yet. And Sam can talk about that procedure and his experience having it done.
Thank you, Dr. Greenstein. So I had keratoconus in both of my eyes for about 25 years. Luckily, my left side didn't advance much, so it's pretty mild. My right eye, on the other hand, advanced quite a bit, completely being useless with glasses and seeing at best about 20/60 with scleral contact. So recently, I've been researching some procedures to improve vision for keratoconus patients, such as CXL and PRK combination treatment. But what got me interested in CLEI is a unique procedure they offer called CTAK. It's a procedure where donor corneal tissue is inserted into a patient's cornea to increase thickness, thus providing a more natural shape. So having a thin cornea on my right eye, it just kind of made sense logically to be treated through this procedure first prior to getting other treatments. So back in March of this year, I was treated in my right eye with CTAK, followed immediately by an Epi-on CXL, CTAK for enhancing corneal thickness and shape, and CXL to lock in the new changes. Combined surgical process took about 50 minutes, 20 minutes for CTAK and another 30 for CXL. My right eye received numbing drops, so there was no pain whatsoever throughout the whole process. The hardest part of the surgery was pretty much just staying still and making sure to look at a fixated target for the whole process. Immediately following the treatment, I was seeing much better from my right eye. To give you an idea of how much of a visual improvement that is, previously when I saw a light source, it used to just blow up to the size of a basketball. After having the treatment, though, that distortion size reduced to a size of maybe like tennis ball. This change in visual acuity was immediate and not something gained over time. It was pretty amazing, almost miraculous. So just like that, I was seeing much better. And honestly, I haven't seen this well since perhaps like 15 years ago, before the time when my keratoconus became more advanced. In terms of recovery, my right eye was in some pain after numbing drop wore off, but after one night of sleep, there was no pain at all. I didn't notice any additional haze, glares, nor streaks after surgery either. Furthermore, I didn't have any serious light sensitivity issues either. So I was pretty much out and about within the next few days with sunglasses on. So after 3 months of healing, I'm now in a position to get a PRK treatment at CLEI to further improve vision in my right eye. And I'll be getting that soon. And after healing from PRK, I'll be getting my final prescription in a few months. So just from CTAK, I right now have a more of a balanced vision because my right eye was much worse than my left. And as a result of my right eye getting much better, my vision is a lot more useful, combined vision is a lot more useful and functional. I have stopped wearing a painful rigid lens altogether. And even right now, I'm getting by glasses alone. In the end, I'm glad to have received this treatment because it provided an immediate visual improvement with minimal side effects, quick recovery time, and providing a thicker cornea to be treated with PRK for further correction. It is my hope that CTAK procedure can become more mainstream, and I just wanted to share my experience. Thank you.
Thanks, Sam. I'm going to actually just take 1 second here to show a couple of additional slides, only because CTAK is such a new procedure. And I think your explanation and your description of kind of what people are describing to us about their vision change from it has been, really, really amazing. So I'm going to just show a couple of brief slides here. So just to give an idea, this is the average outcome. So this includes Sam's experience. On average, patients' glasses without correction, so without glasses, vision has improved from about 2,500, so basically worse than the big E, to around 2,120. And vision in glasses has improved from about 2,160 to 2,070. So Sam, I know your vision actually has improved even more so than that, even without having the PRK done. I think your vision, when we tested it, was even better, a little better than 20/40. But these are the averages that we're getting on a very wide range of patients. So just to give some sense of that with the eye chart, the vision without glasses on the left is basically from off the chart to now getting down to the 2100 line. And then again, the vision on the chart goes from the 2200 line to somewhere between about 20 to around 2060, 2070. So again, an example of this process happening, once the segments are placed, you can see these in the bottom right, these large red and pink areas where the steepening is, how reduced they are from placing these segments and how flat the cornea gets in blue. And again, this is one of the cases where the vision was about 2100, went from 2100 at 1 month to 2050. And like you said, that vision correction happens pretty quickly. You can see it, pretty fast. And for this patient, it was 2030 in a contact lens. So the flattening we're getting is also very, very different from what we've seen with our other procedures. We're getting over 10 diopters of flattening here. So 3.5 with the laser, and now close to 10.5 with CTAK. So the one thing I did want to just show here is the CTAK is being done as part of a clinical trial, which we are still currently recruiting patients for. It's a trial that's sponsored and done in partnership with a company called Cornea for patients who have keratoconus and ectasia. And so in general, the trial involves, and maybe, Sam can speak a little to the experience, but you have to undergo a screening, and then we need you to follow up after surgery 1 day, 1 week, 1 month, 3 months, and 6 months. If you're part of the trial, unlike Sam's case, we can't combine the cross-linking. So the cross-linking has to be done separately 6 months later. But normally the procedures can be done simultaneously like you had done. And then we can, like you talked about, come back 6 months later and add some correction with the laser, which we're going to do now for you. So I just wanted to give some context to the CTAK procedure in general, because it is so new. But I think you described it great, perfectly, which is, that we're really starting to see results in corneas that we never thought people would see this well in glasses.
Dr. Greenstein, I do have one question for Sam that had come up before we go on. A patient had asked specifically for you, was there any haze or level of cloudiness that comes from the new inserted tissue in your eye? Do you notice any difference?
No, absolutely no haze or any. It didn't add any. It actually reduced the higher order aberration that I had from keratoconus. It didn't add any distortions as a result of CTAK.
Thank you.
Great. So I think Dr. Gellies is going to pop on now.
There we go. Okay. Waiting for the camera to actually show up. So thank you very much. We really appreciate sharing that perspective on CTAK. So next, I'd like to go ahead and introduce Camille, actually Dr. Cohen, who is a colleague of mine and actually a former intern. And she's going to describe, her experience with CTAK and scleral contact lenses. And I'll turn it over to Camille.
Thank you so much, Dr. Gellies. So I attended school with Dr. Gellies, and one of my first rotations, he was my preceptor. And while on the rotation, I mentioned that I noticed certain changes in my vision. I've always been very nearsighted, but at that point, I was noticing that the chart just looked different to me, that I felt that I wasn't getting to 20/20. And he did a topography on me and informed me that I had keratoconus. And I told him no, that he was wrong, and that my brother has keratoconus, but I don't. And he informed me that I was wrong and fit me in my first pair of scleral lenses. I am not a compliant patient, and I did not keep the sclerals on. I did not like that they would fog after a few hours, and if it's a busy day at work, I just couldn't be bothered to take them out and put them back in. And at the time, I was in my late 20s, and I had fairly stable vision with glasses. I was still about 20/30, 20/40 in my left eye, probably 20/25 in my right eye. But over the last few years, I noticed that my vision was changing, more specifically in my left eye. And living here in New York, I walk everywhere. And during the winter months, when it's darker earlier, I noticed that I really was disoriented walking home at night. Dealing with lights, I just saw so many halos and felt at a certain point unsafe. And even trying to do charting for me, looking on the screen with my glasses on, I was starting to notice double vision, which I never had before, and filling out forms that I wasn't filling out on the correct line, that I was either above or below because it was splitting on me. So I reached out to Dr. Gellies, and I was very happy to see he was still on the East Coast, and he told me about the CTAK procedure, and I came in, and Dr. Greenstein did my left eye, I think in March of this year. And I would say pretty painless procedure, as Sam mentioned. Just for me, light sensitivity was the main thing, but I would say by the next day, the first thing I noticed was that if I closed my right eye, I no longer saw diplopia, I no longer saw double vision. I could make everything single, and that was something that hadn't happened in a few months. So right away, I noticed a change in vision. I was refit in new sclerals, which are much more comfortable for me than my old sclerals, and I am seeing basically 20/20 with my sclerals in, which is exciting.
So I went ahead and swapped spots here, so Dr. Greenstein here, so that I can go ahead and share a few things as far as a little bit of details about the procedures and the use of contact lenses in this case. It's very funny to think about this. It was almost 10, 12 years ago that I fit Camille with her first set of lenses, and the technology has come just light years from where it was previously. So at this point, hopefully you guys are seeing the screen now. Is that correct? Seeing the PowerPoint there?
You're good.
Excellent, very good. Okay, so guys, so basically what we're looking at here is, we like to take a comprehensive approach to keratoconus management at CLEI. The main thing being here that we want to approach this in a three-step manner. The first one being stability, the second one being to improve corneal shape, and then third to correct the remaining prescriptions that are present. When we look at this, like Dr. Hersh had mentioned before, stability is really achieved by using corneal collagen cross-linking. We want to stop your disease from getting any worse so that we can keep you at the level that you're at so that you don't end up continuing to move forward to advanced disease and the possibility of needing a corneal transplant. Now, when we get to the second step here to improve corneal shape, these are where procedures like INTACs or topography guided PRK or CK or CTAK all come in. These are all purposefully changing the corneal shape so it can make the vision more correctable when you're not wearing contact lenses. Now, last, and that is likely the most impactful of all the procedures that there is the CTAK procedure. Lastly, step 3 would be correcting that remaining prescription, and that comes in the form of glasses and contact lenses. And contact lenses can take a variety of different shapes, whether that's corneal gas permeable lenses like classics, or custom soft lenses, scleral lenses, hybrid lenses, piggyback lenses, pros devices, all of those. Now, so how is vision affected in keratoconus? Well, we know because of the irregular dome shape, or rather in a normal eye, we have a regular dome shape, and that allows the light coming into the eye to focus to a single focal point. Whereas when we have an irregular cornea that's bulged and protruded, it creates a variety of different focal points in the back of the eye that creates a doubled, overlapped, halo, flare, glare, ghosted image like what you see on the bottom there. Now, those overlaps can be described as aberrations. Aberrations just basically mean a smearing of light. And they're classified in 2 orders. There's lower order aberrations like nearsightedness, farsightedness, and astigmatism. And those are things that can be fully corrected with a pair of glasses. And when you correct those individuals, you can correct their vision entirely. You give them very clear vision. Whereas higher order aberrations, the type of blurring that's created by keratoconus, are not entirely correctable by glasses. These higher order aberrations contribute to the quality of the vision. So this is the sort of thing that a patient with keratoconus might see, very similar to what Camille might have experienced in the left eye prior to having the procedures and prior to having the scleral lenses. So when you look at this, it really contributes to the quality of the vision, and it is pupil dependent, right? So during the day when your pupil is smaller because it's bright out, your vision is a little bit clearer, but at nighttime, like Camille was describing, with a larger pupil, you're going to get more aberrations, and that really increases the glare and halos that you see. So let's take an example here. This is a model eye, and let's say we're projecting a grid of little spots into the eye. They're evenly spaced, they're very defined. This eye, this model eye, has no aberrations present and should have a absolutely perfect visual outcome. Now, in the normal corneal patient, you can see that we have a few aberrations. The vision isn't quite as sharp as the model eye, but it's very, very good, and that's what we should expect, and we should get a very good image out of that. But when we have keratoconus, you can see how there's a lot of aberrations present, a lot of irregularity, and you can see how that distorts the vision. And when we add a pair of glasses to that, it improves somewhat, but you can still see those higher order aberrations present. Now, when we use specialty contact lenses, what they're doing is they're masking the irregular corneal shape to allow the light to better focus on the retina. It's not perfect, but it's much, much better. When we add that in, you can see that there is an improvement in the vision that this individual experiences, and it can give them a much clearer level of vision, but you can still see that there is some ghosting and aberration left over, this residual higher order aberration. So with a standard scleral lens, an individual may experience the vision like what's on the left. You can see that little bit of smeariness to the vision, but it's still good vision. With higher order aberration correcting scleral lenses, we're able to correct the vision even further and give individuals a much higher quality level of vision and improve their level of vision to levels that they can be very happy with. Many individuals, especially those with advanced diseases, struggle even with scleral lenses because the vision just isn't clear enough. And this technology can help clear that up even further. So you can see the comparison between the two, the crispness of the vision on the right with the higher order aberration correcting lenses. When we look at the data so far out of our pilot study, what we could see is that with the higher order aberration correcting lens or the wavefront guided lens, individuals were gaining about 2 lines of vision from where they were previously with their normal scleral lens, and had an average of about a 62% reduction in the aberrations in their vision while wearing the lens. So what does that mean? That means these individuals with the standard lens were here, and with their higher order aberration correction lens can get down here to 20/20. So these are on advanced eyes. When we looked at the eyes that were using the technology, they had an average Kmax of 64 diopters, which is a very severe case of keratoconus, with a IS ratio of 15.5, basically meaning that there's a lot of asymmetry from the top to the bottom of the cornea, indicating that there's high irregularity present. And these individuals were able to achieve 20/20 vision. So this is something that's been very, very promising for individuals. With that, Stacy, are there any questions for Camille that have come through?
Yes, we have one question specific for Camille. So a patient asked if she experiences fogging with your new scleral lenses that you're wearing now.
No, I do not. I have not had any fogging with these newer lenses. I do believe I'm going in for a few more procedures, so we have a little way to go, but as of right now, I do not have any fogging. They're much more comfortable for me, and I can wear them longer than I could previously.
Thank you. All right, Dr. Gillies, were you done? Because if so, I have a bunch of questions.
I think we're going to ask all the panelists to come back on at this point, and I think Stacy will fire away.
Okay. All right. So actually, a couple people asked the same question. They wanted to know if somebody that already received crosslinking, they had the traditional crosslinking years ago, they got minor improvements. Will they still benefit from laser crosslinking at this point? Like, can you do the crosslinking twice with laser and still get a benefit from that?
Well, what you can have are supplemental procedures. Remember, crosslinking per se was strictly to make your cornea more stable. We would likely not do crosslinking again if your cornea has remained stable. Rather, we can think of another kind of intervention like topography guided PRK, which is a close cousin to the laser crosslinking. The topography guided laser makes the cornea smoother. So it decreases the height of the cone, makes the cornea much more regular. That decreases the visual static. So think of the poor vision that one gets in keratoconus as being visual static. It's like static on your television. There's light that's coming in the eye that's not perfectly focused. So somebody like you may be a candidate for topography guided PRK to smooth the cornea and give yourself a better surface. Sometimes intacts are suggested in a circumstance, depending on what your cornea looks like, and other procedures as well. It depends on the exact needs that you have. What's the shape of your cornea? What's your vision? What are your visual needs? Is your cornea stable? How thin is the cornea? We have room to work. So all those things are taken into account to choose the procedure that will get you the best outcome.
Thank you. All right, I have a patient-specific question for Jay that came after you had already finished talking. So the patient was interested in wanting to know what type of contact lenses do you wear now, if you wear them?
Yeah, so I'm fitted for soft contacts, and admittedly, I'm probably not the best student when it comes to doing my homework, but you know, when I have them both in, my vision's close to 20/20 in both eyes and really sharp. Without them, my right eye, which did not have keratoconus, like 20/30. My left eye, you know, I guess it depends on the day, but probably like 20/40 or 20/50, something like that. So yeah, I wear them at times, like when I'm playing sports or, you know, if I am reading or something like that, I want that sharp vision, but, you know, I'm pretty comfortable without them as well.
That's great, thank you.
Excellent. I want to just add one quick thing to Jay's comment there, which is that many of these procedures can actually make contact lens fitting much easier and allow us to use much less complex lenses. When we go through the process, many individuals who are kind of on the moderate scale may need a more complex lens simply because we're not able to fit their corneal shape very well. Whereas if they have a procedure such as topography guided PRK or INTAX or CTAK, it can create a more even curvature, which then can allow us to use things like a soft contact lens, which can be beneficial for many individuals going to a more simple solution.
Thank you.
And you're able to fit lenses with people with different kinds of problems. If they've had intacts, if they've had topography guided procedures and the like. Yeah, do you choose different kinds of lenses depending on what the procedure has been?
Absolutely, absolutely. When you look at the various different types of procedures out there, they all necessitate various different types of lenses to avoid, you know, complications with the procedures, but also to get the most maximized outcome out of the procedures as well. If we think about a patient, you know, the comprehensive vision needs of a patient, it's important to, you know, have these procedures to cover the time that you're not in your contact lenses, right? Many of these the individuals with keratoconus rely heavily on their contact lenses, but then when they don't have their contact lenses, they may not be functional. So having these procedures are very, very important, and having the variety of different contact lenses to support those individuals is extremely important as well. We actually just finished doing a retrospective review of the patients here and found that we had I believe it was a 98.2 success rate on all patients that we attempted to fit in contact lenses. So it's, you know, having the right types of contact lenses, a knowledgeable practitioner to fit those contact lenses who understands the procedures and you know, can get you a good outcome is extremely important in that area.
Thank you, Dr. Gellies. All right, so I have a question from a patient about the removing of corneal material. So he asks that it sounds like some of these procedures sound like they're removing corneal material, which he thought that was kind of contraindicated for keratoconus. So can you kind of go over, I guess, why, if that's what we're doing, why it's okay?
Sure. So So it is true that in general, we want to remove as little corneal tissue as possible, since clearly in keratoconus, corneas are generally thinner than normal. With the advances of cross-linking and the ability to stabilize the cornea and strengthen the cornea, we have found that we can now remove small amounts of corneal tissue, much less than we remove with traditional LASIK or traditional PRK to correct your and get you out of glasses. We can remove small amounts of corneal tissue to improve your vision, improve your glasses correction and contact lens correction, and stabilize the cornea at the same time. That's why when we talk about doing these procedures, while Michelle was lucky enough to get out of her contact lenses and glasses for distance vision, that is not always possible or always the goal with these procedures. The goal of these procedures is to try to improve your vision in glasses, in contact lenses, and if we can do that without, then that's an added bonus by removing as little corneal tissue as possible. And we always recommend that you need to have cross-linking done either before, after, or with these procedures to stabilize.
I want to reiterate that the cross-linking is the critical component to allowing us to do some of these other procedures, because you need to make the cornea more rigid and stable so you're not at risk of progression as the years go on.
So if a patient already had cross-linking years ago and now they're coming in for PRK, is it potentially the fact that you're going to do cross-linking again?
It depends on what the history is and how severe the keratoconus is. If it's been many, many years and we are doing something like the topography-guided PRK procedure, we may supplement it with cross-linking. Very frequently in those cases, we do what's called an epi-on approach, which is faster healing and easier for you, but just to add a little more strength to the cornea so we know down the road the cornea will remain stable and not progress.
All right, thank you. All right, let me run through some of these a little quicker because we have quite a few. Now, is it possible for somebody that had LASIK surgery? So I guess they had LASIK, now they have corneal ectasia. Can they have PRK or Intacs after that?
Yes.
To help improve their vision?
Yeah, we did two studies initially that led to approval of cross-linking. One was for progressive keratoconus, and the other was for keratoconus or corneal ectasia after a LASIK procedure. And number one, very effective still is cross-linking and decreasing progression in that circumstance. And number two, we've also looked at Intacs and supplemental procedures in that kind of problem, and they too can be very effective. What we have found in many cases, indeed, is that Intacs sometimes might be even the preferred approach in the circumstance of ectasia, because the cone that develops tends to be in a position that's well corrected. But certainly a eye that suffered corneal ectasia is amenable to a lot of these treatments.
Thank you. Michelle, I have a question for you from a patient. So she wants to know, what types of things did you experience that you felt like you wanted the Intacs to come out? I guess what made you want to come back into the office for that?
Yeah, I had a ghosting that were like I don't know if it was a double vision, or I guess I would call it a ghosting from my left eye. So I would notice it mostly in dim situations where there was lighting, so I could see it, the edge of the TV, I would see it, or if I was looking at a clock in the dark, I could see, 2 3s instead of, and I played around and kind of figured out that, it was related to one or the other, and Dr. Hersh was really good about helping us try to figure out what it was, and removing one of the, ultimately we swapped out, tried a different Intact, and then removed another Intact, and or one of the Intacts, and it seemed to help a lot. So Yeah.
Or we have to try another size first to see if that would help.
Correct.
You've had a lot done. All right, so for any of the patients that are on that wear scleral lenses, how many hours do you wear on average throughout the day? I know, Camille, are you the only one here that wears scleral lenses, I guess? How many hours do you get from your lenses? Like, do you put them in the morning and then take them off at night, or do you only wear for 8 hours?
No. Initially, the old lenses I could maybe get 4 to 5 hours. I've done 8 hours in these, but then I have to take them out. I also am not the best patient, so there is that. I prefer just throwing on glasses. Part of that is that I'm lazy. So, but the actual comfort when I get them in, I can keep it a solid 8 hours.
Thank you. Okay. I guess this is more of a technical question for one of the doctors. So a patient wants to know, how is the corneal material for CTAK actually attached to the eye? Like, give us some guidance on that.
The CTAK material is actually human cornea. It is obtained by the eye bank, and most of the corneal tissue that the eye bank gets is used for corneal transplantation. But they take some of this tissue, they can preserve it. So corneal tissue now can be preserved for many years. Corneal tissue really in this case is corneal collagen. So though it is from a human donor, the cellular structure is removed, and you're really dealing with what we call a melee or pancakes of corneal collagen. So when we do the CTAK procedure, we shape the corneal inlay, the corneal collagen inlay that we're doing with the laser. That is shaped dependent on the contours of your cornea. So we look at your maps, we see where the cone is, we see where the high and low spots are and how large they are. And we can do with our laser is shape the proper thickness and conformation of the tissue to place within the cornea. It's then slid into the cornea between the natural melee or pancakes of the cornea. The cornea is made up of really 500 pancakes of collagen. And we slip the tissue within a plane in the middle of the cornea. So it's taken up like natural corneal collagen, and we think ultimately simply grows as part of your own cornea.
Okay. Now, if you have intacts placed in your eye, do you need them removed before you had CTAK if they weren't going well for you, or can you have the intacts in there and still put more tissue in?
I mean, each case is going to be different, but in general, you're going to have them removed. So, there is maybe a possibility if you had 2 segments that were placed in the past, that only one would have to be removed, but that's probably the less likely scenario. For most patients who we've done CTAK for who had previous intact, well, really for all patients who we've done CTAK for so far that had previous intacts, we did remove this segment. You do have to wait a few weeks after the removal to undergo the CTAK procedure. We generally do it about a month apart.
Thank you. Dr. Hersh, I have a follow-up question for you about the tissue. So the corneal tissue that we use for the CTAK, so you said it's all green from the eye bank. So does it ever reject, like a corneal transplant could reject? Can that tissue reject in the eye when you put it in CTAK?
In theory, it could, but the important point here is there are no living cells in this tissue. So when a cornea rejects, as in a corneal transplant, it's not the collagen that's being rejected. Rather, it is what we call the endothelial cells and the keratocytes, which are cells within the cornea itself that are rejected. But what we're dealing with here really is just corneal human collagen without cells. So the risk of rejection, though it is possible, is minimal. We've not seen a rejection episode in our program.
All right,
Steve,
now,
just-
Michelle,
sorry.
I have oh, I'm sorry.
Yes, no, sorry to interrupt a second. Michelle, maybe just briefly, can you describe the experience of having the intacs removed? What that involved? Was it a big deal to have it done?
Having the intact removed, mine was in for a while, so it was a little tuggy. I think there was a time or two in the procedure I mentioned that it wasn't comfortable, and Dr. Hersh put in some more drops for me. So it wasn't my favorite of all the procedures. It wasn't awful, but I much prefer having them in than having them out. Yeah.
Yeah, so people have different, and it actually sometimes has to do with length of time, sometimes not. But for some people, they do slide right out, and for others, it can take a little bit of time. But in general, once it's out, the recovery is usually pretty quick from there.
Correct. Yeah, my recovery after it was out was very quick. So I think the next day or two, I was feeling very good and fine.
Thank you. And now, Camille, we have a follow-up question on your hours of contact lens wear. So if you put them in and you wear them for 8 hours, then you take them out. If you put re-wetting drops in, do you think that you would be able to tolerate them a little longer if you decided that you wanted to, instead of putting your glasses on? Because I guess not everybody sees as well as you may. That makes sense?
I suppose. No, it makes sense. I've never put my lenses back in. Once they're out, I'm usually done for the day. But I suppose if I put re-wetting drops in there, then I would be able to wear them a little longer. Knowing my personality, that would not really work well for me. But ideally, yes, I could wear it longer.
I know everybody is different with, how long they tolerate the lenses. So thank you.
I think I think if I put the re-wetting drops, I could probably get a couple more hours out of it.
Mm-hmm. Okay. 8 hours is, a fairly long time, if needed. So that's great.
But, hopefully, I think Camille kind of expresses why everybody's different. We have definitely patients who can wear lenses for 10, even 11 hours in a day, and they are, pretty comfortable with them. And patients very commonly who have to wear them less. And that's where, as Dr. Gillies kind of described earlier, having sometimes these combinations of treatments done can really allow you to adapt to whatever lifestyle you're hoping to lead, whether you want to leave the lenses in a little bit longer and you're comfortable with that, or you want to take them out a little earlier in the day. Having the CTAK procedure in combination with wearing lenses allows patients to do that more easily than before.
Yeah, I just had a patient actually write that he wears his iPrint Pros for 12 to 14 hours a day.
Yeah, so certainly there's a variety of different wear times that individuals will have. Now, the one thing to mention here that is somewhat important is that there are individuals who, are only functional while wearing their contact lenses, and that can be very problematic because should those individuals be having a problem and they're not functional in glasses or without their contact lenses, that's where real big problems and complications can happen in the form of infections and other sorts of issues, which is where this all becomes very, very important. One, you need to have the best fitting contact lens that you can have. You want to wear it for the amount of time that you're comfortable wearing it. If you're having problems, you need to be able to function, with glasses or without them. And that's where the comprehensive approach that we take becomes very, very important for patients. It's we hear a lot of stories about patients who will have, bad complications. We simply, we don't really see that here because these patients are treated in that comprehensive manner, which allows them to have these, experiences where they can not have to rely on, contact lenses when there's a problem.
Sam, I was actually wondering if you could comment for CTAK in particular, since it is such a new procedure, what really made you settle on choosing that as the kind of direction you wanted to go in?
For me, it was basically just wanting to get out of contacts altogether. Just like you said, as I've been getting older, contact tolerance has been declining, and just wanted to get my vision good enough for my right eye, especially make it more balanced my left eye, just to get by with glasses alone altogether. Ditch the contacts, and with CTAK alone, I'm already just using glasses, and hopefully with after topography PRK, it'll be even better.
Great. Well,
I thank you.
Maybe one last question?
Do we have time for just a couple more?
I think we could do a couple more, yeah.
Quickly.
All right. All right. First of all, I wanted to let everybody know I've had a few questions from people asking how they can get qualified for the CTAK clinical trial and how do you proceed. Please just either call the office, ask for Stacy, or you can send me an email and I can go over the steps with you. So I just have just two more questions. I'm so sorry, hold on one second. So what are the drawbacks of using soft lenses, whether they're standard soft or custom soft, for more time than is recommended?
So most contact lenses, individuals can safely wear lenses for about 12 hours, which is really what's labeled on most contact lenses. Many individuals wear their lenses anywhere from 12 to 16 hours a day, which is totally fine should your eyes tolerate it. There are complications that can arise with extended wear, and that typically comes from individuals who are ignoring the signs of problems, such as irritation at the end of the day, redness at the end of the day, those sorts of things that could lead to opportunities for infections and other things like that. It's very important for you to be able to listen to your body. If you are having problems, you need to, either reduce the amount of wear that you're having with them. Most importantly, you need to have a doctor who knows how to fit your contact lenses and find that they are the most appropriate for you and fitting the way that they should and performing the way that they should. Beyond that, if you're having problems with your lenses getting into that later part of the day, you need to discontinue wearing your lenses a little bit earlier in the day so that you're not having those problems. And in those cases, you may want to consider having a second opinion, having an individual refit in a different type of lens. There are a lot of variety of lenses these days that can be very successful on individuals.
All right, thank you. I have one last question I want to ask. Let me just, my screen moved. So this patient has, hold on. All right. Okay, so sorry about that. So this patient is non-functional without contact lenses. So really, if he's having a bad day, you really can't do anything. Right now, they're working great though. So if there ever comes a time where they stop working great and they can't fit it with anything else, is that the time that one can look into CTAK or other options?
So, I mean, I think part of what we, I think tried to show, I think what has been described tonight, is that you don't necessarily have to wait to the point that you can't wear your contact lenses to move forward with the CTAK procedure. We definitely have offered it to patients. For example, Sam's case, he didn't want to wear contacts anymore, and he happened to be a candidate where we felt like we could get him into a comfortable glasses prescription and balance out his eyes. But like Camille, she had a case where I think, Camille can correct me if I'm wrong, but we had discussed before doing the CTAK procedure that the goal was never going to be that she would not wear any contact lenses, but that the goal of her procedure was going to be to make the vision as functional as possible in glasses and to wear contacts to get better vision than that. So you don't have to, the answer is you don't have to wait to necessarily be unable to wear contact lenses to do the CTAK procedure. And in fact, there may be reason to think about doing it earlier, because if you can decrease your lens wear now to a certain extent, that may actually make it easier for you to wear lenses longer term.
Thank you. And I think we went over enough. So
again, we really want to thank our panelists here, our panel of patients. We really appreciate your time coming on and sharing your experience. And hopefully everybody here learned a lot from your experience for them going forward.
And for everybody else, we're always available for any questions that you have. They've not been answered here. This webinar, just email us and we will be happy to entertain any questions that you might have. Thank you.
all right. Thank you, everybody.
Thank you.
Good night.